Well, again, this is Jack Davies, and based on our experience with the personal health record, we absolutely made the decision to take that approach, which is identify what seem to be the high priority data elements and focus on those and get those right. So as I said, we started with the medications and allergies because both the physicians and the patients said if we couldn't have anything else, this is what we would really like to be able to share. And we're, as I pointed out, we're finding a lot of complexity with that. So I think the idea of not trying to do everything at once in the way of health information exchange, but taking it a step at a time with the high priority data elements that are going to provide the most clinical value is a very logical way to go.
You know, we're talking as if there is a provider electronic medical record and there's a personal health record in the hands of the consumer. But there's an intermediate step here, and that's a case manager, care coordinator, for especially chronically ill with multiple providers and multiple chronic conditions, and providing them access to a combined record that may be fed by some home monitoring devices for the patient, but that is able to provide information to a case manager who may not be a physician, but who is following up, making sure things happen. I think we've had great yield with actually pulling paper chart abstractions in North Carolina and managing the Medicaid chronically ill population. It's shown some great economic benefits and some great quality benefits. So there may be this intermediate step that thinking not just of a hospital record or practice record or the record in the hands of a patient or person, but the case record.
So it's a lot of different ways to respond to that. I think that in the first question, what's the basic level of information? I would actually suggest that we start with the data elements that are recommended coming out of the HIT policy and standards committees around sort of high value, high priority clinical data elements, you know, the A1C levels, LDLs. There are probably other things in there that we'd really like to get at, like ejection fraction, so that we can understand the care of people with heart failure, but that's probably a little bit beyond what we would like to see. For the how, I think we want to look at those organizations that are already beginning to do this. So, you know, again, the Taconics, the PCIPs, Inland Health, and others. I think that they haven't been proven yet, but I think that the extension centers are intended to do this. It's going to be a little while before they get spun up. But I think that, again, there are folks who are able to do this and have sort of baked in having the clinical data for multiple uses beyond just patient care, right? Clinical data that can be used for multiple purposes that have been able to make this work. So we probably want to look to them.
For our listening audience, that was Phil Renner who was just speaking, and prior to that, that was Holt Anderson.
Hi, this is Jerry Hinckley. You know, I think, you know, no disagreement with any of those responses. They don't get all the way to what we're supposed to be talking about today, which is the accuracy and integrity of that information. And so if you can decide on kind of the data set, then the challenge is, can I rely on it? You know, and you know, I guess what I'm arguing for is let's have some rules of the game around that. And I think it's hard work to do that. You know, maybe we'll never reach consensus on it, but I really think for the you know, for the furtherance of why we're all here together, it's work that we need to do, and it all builds on all the reactions that the panel gave in response to this, I think.
Thank you, panelists. The next question is from Michael.
Hi, thank you. Mike Lardier from the National Association of Community Health Centers, and thank you very much for the presentation. It's very helpful and enlightening. My questions are around this is a moving target, and we're trying to follow it. So it's really a question is a couple of themes that a couple of the presenters had, like Jack, around you finding that problem within Google with the hash mark, whatever it was, that made the transmission not go through. Art, you identify that Cal Rio came up with its own algorithm for the master patient index, and Jerry, you identified that there's the DRSA, and then people are trying to change or make it better for their own organizations. So my question is, are we tracking any of these in terms of best practices and putting them out there? Like, is everybody working on doing their own algorithm, and do you have one that's better than others, and are we sharing that? Are we sharing contracts that are improve on the DRSA? Are we tracking in the Google that, hey, don't do this because you know it makes it go out? Are we collecting any of that any place or tracking it?
For that particular project, yes, and certainly we're publishing lessons that we've learned from our other experiences with EMRs and hospital information systems and information exchange. Are we doing that in a formal manner as part of some national body that is aggregating all this information? No, it's more at the state and the regional level.
I'll just quickly respond. This is Arthur Davidson. In Colorado, we are part of the state and regional demonstration project, which Rhode Island is as well, and AHRQ is writing a formal evaluation. We submit evaluations to them, and they're writing up a large report about the 5-year project, yes. And that's included in there. The next question is from John Tucker.
Well, good morning. This is John Tucker from the NCHICA Board. And I'm looking at this from the perspective of the practicing physicians. And I really applaud the intent to have as accurate data as possible in taking care of patients. When I think of data, though, and it's interesting the terms that are used throughout here, that data and information are sometimes viewed as being interchangeable. And I think in practice that you view data more as single elements that you might get from a laboratory data. But information may come from multiple laboratory assessments over time in which you know what the history of that particular patient is. And there's an exponential increase in the power of that once you have that information. And when you look at a personal health record compared to an electronic health record in the care of patients, I think the sense is that for their personal health records, it's more about individual pieces of data, and in practice with a patient over time, that you are looking for how this patient is transitioning over time. And increasingly now, even if the data are accurate, and I was particularly impressed with why Jerry went last, that looking at these data, even if they are accurate, what is usually assessed in the sense of being held accountable and liability is not the accuracy of the data, although that may be important, but how those data were used in the care of a patient. And that makes the interactions much, much more complicated. And there are some interfaces here that are coming together that are going to be pretty profound and very, very difficult. Because now we're seeing more and more with and I would say that the recent experience with the mammography guidelines is a good example of that, of not only information but now knowledge being applied to medical practice, and this relationship of what patients may want to know, not just from data or information, but now knowledge being applied to their care that has to now interface with the medical community. When you think of the volume of work that's going on right now, we're approaching 1 billion outpatient ambulatory visits a year now in this country. 1 billion visits now. It's just an astounding amount of information that's being generated in the care of patients. And I can understand from one point of view where you'd want to be as parsimonious as possible, and I think Phil spoke to this, of getting the right information and data sets that will help inform the remainder of practice. But that's more related to population a management of the practice than it is in how you're going to be assessed for the care of an individual patient, which means everybody and all of this stuff now. So you can't boil the ocean, but at the same time, you almost can't stop boiling the ocean when you think of how much complexity there is in the care of patients. And one of the things that impressed me with the comparative effectiveness research is the foresight of the IOM committee, that that a lot of it was about comparing treatment A to treatment B, but a lot of it was about understanding how we actually take care of patients. And when we talk about workflows, I would submit at this point that we don't know a lot about what actually happens in the complex interactions around the care of patients, and that we're focusing on picking bits of data for their validity, but having a much harder time of incorporating that into how patient care really takes place. And it can only get more complex than what it is right now. So I hope that comparative effectiveness research will look more at health services research and lessons learned about how we actually take care of patients. But this has been a great exercise, and I think just the reason why we want to have these stakeholder forums here at NEHC. So thank you.
Linda?
Thank you so much, Linda Fischetti, Department of Veterans Affairs. First of all, thank you all for an excellent panel this morning. I think in many ways you show the leading edge of the conversation. As a nation, we're spending a lot of time talking about health IT adoption, health information exchange, and you're really leading us into, well, what are the ripples that will come from that? And so the excellent conversation. I appreciate also approaching NHIN. So many times you see it approached from the technical standpoint, where, as we all know, the technology is the easiest part of this. It's everything else that comes into it, the workflow, the legal implications. And so the one person, though, that I did not hear speak about NHIN was you, Jack. And I wanted to ask, have you within your organization had a conversation? Do you have a business case? Is there a need that you see to move towards the NHIN? Or is that not something that you have on your glide path? Thank you.
This is Jack Davies, and yes, we are looking at the NHIN, the Connect Gateway, in particular for sharing data with federal agencies. We are currently in a project with the CDC, their Situational Awareness Project, to collect syndromic surveillance data from across many of our hospitals and send that both to the state and the federal public health agencies. Currently, we're just doing it directly through the CDC's NEDS Gateway, but we're looking at moving to the NHIN Gateway. And for anything else we want to do with the VA, for example, we would probably be using that mechanism. Whether we would be using it more at the local or regional level, I think is a little bit further down the road.
Thank you.
We're coming close to the end of our time for discussion. I have one question online here from Kathy Kenyon in the Office of the National Coordinator, Policy Analyst. This is a question for Jerry. Assume that the EHR will affect the liability standard of care, both with regard to use and exchange. What are your thoughts on how to inform what that standard of care should be? Do you have thoughts on private accreditation, government certification, or government regulation, e.g., for example, the FDA regulation of an EHR? Are credible best practices enough?